In this module, I am going to discuss about an important condition of birth asphyxia, which is also called as perinatal asphyxia. It refers to a problem in the baby due to some conditions during pregnancy or labor, which leads to impaired gas exchange in the fetus. Impaired gas exchange. And this impaired gas exchange would lead to obvious problems in the baby in the form of hypoxia, hypercarbia, and lactic acidosis. In fact, the main feature by which we can make a diagnosis of birth asphyxia is by the presence of acidosis. This acidosis is characteristically noted in the umbilical arterial blood and is defined by a pH of less than 7 in the umbilical artery. That is how we traditionally define birth asphyxia in the baby. WHO definition of birth asphyxia is a simplified one, which tells you that birth asphyxia is a condition which should be considered in any newborn baby wherein the baby is not breathing at the time of birth or not able to sustain breathing at the time of birth. So it is either fail to initiate breathing or fail to sustain breathing at the time of birth. That is what is called as birth asphyxia. This is according to the WHO definition. Now, we should also know about the consequences of a baby not breathing at the time of birth. Obviously, when the baby is not breathing, air is not entering inside and there would be hypoxia. Okay, and we all know that hypoxia is going to affect the different parts of the body, and the main area which is affected by hypoxia is the brain. And the brain damage which is caused by hypoxia is what we call it as HIE or hypoxic ischemic encephalopathy. Okay, so the main organ affected is the brain. You should also know that other organs can be affected due to hypoxia as well, resulting in multi-organ failure. Okay, now among the different organs which are affected other than the brain, the most common organ to be affected would be the kidney. And in the kidney, especially the proximal tubule is more sensitive to hypoxia. And what would be the feature? The tubule would undergo necrosis, or in other word, acute tubular necrosis would develop, ATN. Okay, that's an important feature related to hypoxia affecting the organs. Okay, third important feature is at the level of the tissues. We all know that because of lack of oxygen, there won't be any aerobic metabolism. It would change to anaerobic metabolism. And because of this anaerobic metabolism, it is a lactic acid which is going to be produced. Okay, so in this condition, there would be lactic acidosis. Okay, right. And what would be the Apgar scores of the baby which is not doing well at the time of birth? Obviously, it is going to be low Apgar score. And low Apgar scores is defined by a score of less than 7 out of 10. Okay, these are the different features of birth asphyxia which you should know about. Okay, and as I said before, the most important organ to be affected is the brain in the form of hypoxic ischemic encephalopathy. So let us look in detail about the features of hypoxic ischemic encephalopathy. As we can infer, hypoxia is a condition characterized by decreased oxygenation to the cells or the tissues. Because of hypoxia, there is also ischemia. What is ischemia? It refers to blood flow to an organ or a tissue that is very inadequate to maintain normal perfusion. So this results in hypoperfusion, and that is what results in ischemia. Okay, right. So it's a hypoperfusion. So the physiological functions of the tissue or the cell could not be performed. Okay. And encephalopathy, as you can infer, is the brain damage due to this hypoxia and ischemia. And please remember, Hypoxic ischemic encephalopathy is the number one cause of neonatal brain injury worldwide. Now, I am going to tell in detail about the features of HIE in newborn baby, but before that, you remember HIE is a condition which is associated with increased risk of death in the newborn period. Okay. Also, even if the baby doesn't die also, the surviving babies can have a lot of neurodevelopmental sequelae. This sequelae could be in the form of cerebral palsy, in the form of intractable seizures, as well as low IQ. Okay, so that is why this condition of hypoxic ischemic encephalopathy is very, very important to know about and also asked frequently in the exams. Now we will see the features of HIE. This is given by a staging system called Sarnet and Sarnet staging. It incorporates so many criteria and it tries to divide hypoxic ischemic encephalopathy into 3 stages, as you can see in the screen. Stage 1 is the initial stage or the mild form. Stage 2 is a moderate one. And stage 3 is a severe form of HIE. Please remember, it is not always that the child will progress from stage 1 to 2 and 3. Depends on the severity. Any of the stage can be a presenting feature of HIE. Okay, so that should be kept in mind, and we are going to discuss about the features of hypoxic ischemic encephalopathy with the help of Sarnet and Sarnet staging. First one is regarding the consciousness. Stage 1, as I told you, is something like a mild form where the consciousness of the baby is usually normal. Okay, and in some cases the baby is even hyper alert. Okay, that is for stage 1. Stage 2 is characterized by baby being lethargic. Okay, letharginess. And stage 3, because the brain is severely affected, the baby would be in the comatose stage. Okay, so this is about consciousness of the baby according to the stage of HIE. Next is the reflexes. In stage 1, the reflexes will be like overactive or hyperactive reflexes. I can remember as easily elicitable reflex. You can easily elicit the neonatal reflex like Moro reflex and all. Okay. Stage 2, the reflexes would be sluggish, not easily elicitable. That is what is the meaning of sluggish. And in stage 3, the reflexes would be absent. Very important and often asked as an MCQ. In which stage of HIE is reflexes absent? Neonatal reflexes. Stage 3, it is absent. Then talking about seizures, stage 1, it is almost like normal. So there is no seizures in stage 1. And stage 2 is actually the stage where you have lot of seizures. And please remember this for your exam, that hypoxic ischemic encephalopathy is the leading cause of neonatal seizures. Okay, and seizures usually occur in the first 24 hours after birth. So in the first day itself, seizure commonly occurs in HIE. That's also an MCQ to be remembered. And in stage 3, because there is no activity of the brain at all, seizures are again not commonly observed. Okay, right. Next is regarding the autonomic involvement of the baby. Okay, right. Generally remember in stage 1, I told you the baby is hyper alert alone. You can remember like this. In stage 1, there is sympathetic overactivity. If you can remember like this, you will easily answer what would be the features in pupil size and heart rate. Pupil size would be mydriasis, dilated pupil in stage 1, as well as heart rate also would be increased due to sympathetic activity. Okay. In stage 2, it is a parasympathetic overactivity. Okay, parasympathetic overactivity. So what would happen to the size of the pupil? It would be constricted or meiosis, and heart rate would be decreased. Okay, right. Stage 3, there is no activity of either sympathetic or parasympathetic nervous system. So the pupil size becomes unequal. And the main point to be noted is they have a very poor or no reactivity to the light. That's an important point. Pupils will react poorly or not even reactive to light. Okay, that's for stage 3 regarding pupil size. What about heart rate? Heart rate is very, very variable. Okay, and in this stage, actually there can be an increased risk of arrhythmias also developing. Okay, so it's a variable heart rate in stage 3. Okay, now regarding the posture. In stage 1, because it is almost normal only, the posture of the baby also will be normal. means like all the limbs are well folded and they will resist any passive extension. Whereas in stage 2, there would be some flexion of the limbs which is still noted. Whereas in stage 3, it would be decerebrate posture, where all the limbs are kept in extension. Decerebrate posture. Okay, right, that is for stage 3. Now looking at the other aspects of Sarnet and Sarnet staging, one is regarding the EEG. In stage 1, it is almost normal, so the EEG is also normal. In stage 2, there would be low voltage complexes on the EEG, and at the time of seizure, you will have frank spikes on the EEG. So seizure spikes also are noted at this stage only. Okay, right. In stage 3, again we have a typical pattern called burst suppression pattern. And in last stages, you have isoelectric pattern. So these are the typical EEG patterns which are observed. Duration. In stage 1, I told you it is a mild form, so the recovery is usually very fast, within 24 hours. In stage 2, it is a little prolonged, 24 hours to 14 days. Whereas in stage 3, it will take several days to weeks. Okay, right. Sarnet and Sarnet staging is not only helpful to know about the features of HIE, it also helps in prognosis or tell the outcome in babies with HIE. In stage 1, almost all babies will have a normal outcome only. According to the textbooks, 99% will have a normal outcome, but practically speaking, almost all babies will have a normal outcome. Okay. In stage 2, 80% of the babies would have a good outcome, almost normal outcome. However, 20% of the babies will have some neurological sequelae. So some part of the brain may become permanently damaged and they can develop problems like low IQ or cerebral palsy. Stage 3 is a very dangerous stage because 50% of the affected babies will die. And the remaining 50% of the babies who survive, all of them will develop a sequel in the form of cerebral palsy, right? So that is what is the importance of Sarnet and Sarnet staging. I have told that some of the babies can develop neurological sequelae, and what type of neurological problem they develop depends on the area of the brain which is affected due to this hypoxic ischemic encephalopathy. There are various factors which will determine what area of the brain is affected. Say for example, it depends on the blood supply pattern of the different parts of the brain, especially the areas of compromised circulation can become easily affected. Okay, number 1. Number 2, it depends on the gestational age of the baby. Number 3, it also depends on metabolic demands of the different parts of the baby's brain. Now, I have put up 2 pictures which tell you about the typical patterns of brain injury due to asphyxia in a baby, right? So, first pattern you can see here is something like this. This is the sagittal plane and you have a infarction, wedge-shaped infarction on the side of the sagittal plane. This is called as a parasagittal infarct, which is a typical type of brain injury which occurs in term babies affected by birth asphyxia. Okay, usually occurs in term babies, called as parasagittal infarct. Now this parasagittal infarct, if you can recollect, it is something like a watershed area between the two circulation. What are the two circulation? This side you have the anterior cerebral artery, on the other side you have the middle cerebral artery. So it's something like a watershed between two different circulation that can result in compromised circulation and can result in an infarction. Okay, so that area of the brain can become damaged. Okay, if you see on the other side, that is a pattern which usually occurs in the preterm baby. What is that? This is the ventricle. Surrounding the ventricle, you are having this area which is undergoing infarction. Okay, so this pattern is called as periventricular leukomalacia. Periventricular leukomalacia. Okay, right. So what is the problem because of this brain injury? Look at the first pattern, parasagittal infarct. Can you see that the motor cortex and the subcortical areas are also affected? Mainly the motor cortex is getting affected, and you can see that the motor control to the limbs are becoming damaged. Can you see that the upper limbs are predominantly affected? In the late stages, it can even extend on the other side, and the lower limbs also can get affected. So, if they ask you a question, what could be the problem or type of cerebral palsy this baby with a parasagittal infarct can develop? One, usually it develops problems in the upper limb. Later, when this infarction extends, it can involve the lower limbs also. Or in other words, all four limbs can eventually be affected. And this is called as spastic quadriplegia type of cerebral palsy. Spastic quadriplegia type of CP. CP here stands for cerebral palsy. So, in term babies, what type of cerebral palsy can commonly develop? It is spastic quadriplegia type of cerebral palsy only. Okay, right. And in a preterm babies, look at what is the area of the brain which is affected. Can you see that this area is affected, and what does it correspond to? It corresponds to the motor distribution of the lower limbs only. So, both the lower limbs can be affected. Think like this. On the other side also, if there is periventricular leukomalacia, which usually happens, both the lower limbs are going to be affected. Okay. Now, this will be called as spastic diplegia type of cerebral palsy. Okay, spastic diplegia type of cerebral palsy. Diplegia means two limbs. What are the two limbs? Both the lower limbs are commonly affected. Okay, so these are the typical patterns which are occurring in preterm and term babies due to brain injury caused by birth asphyxia. Okay, there are also other patterns you should know about which are especially occurring in a term baby. First is called as a focal ischemic necrosis. Focal ischemic necrosis refers to only one part of the brain being affected. That's why it's called focal ischemia. And this condition is associated with the development of focal seizures as well as one side of the body, that is one side, upper and lower limbs becoming affected. So it results in hemiparesis. Hemiparesis. One side of the body is affected. That is what is a lesion of focal ischemic necrosis. Second is something called selective neuronal necrosis. This is also a common type of brain injury in term newborn babies affected by asphyxia, wherein some particular parts of the brain are commonly affected. For example, deep nuclei of the brain, which includes basal ganglia, especially the putamen of the basal ganglia is very vulnerable to damage here. Okay, it's an important question which you should know about. Next thing is hippocampus is also usually affected. The next area to be affected is the Purkinje cells of the cerebellum. They are also vulnerable to damage. So some selected areas I have mentioned which can undergo necrosis. So that's why it's called selective cortical necrosis or selective neuronal necrosis. You can see basal ganglia is getting affected. So the child can develop extrapyramidal movements. Okay. Purkinje cells of the cerebellum is getting affected. So the child can develop problems of cerebellar manifestations like ataxia, vertigo, all those things. Okay. And also, if many areas are simultaneously affected together, they can also develop cerebral palsy with low IQ. So these are the important patterns of brain injury due to birth asphyxia in newborn babies. Okay, right. So what I have told in this section is about the pathological correlation of birth asphyxia in newborns. Right. So let's move on to further discussion of HIE. What is a usual imaging technique which will tell you about the brain damage in HIE? For screening, you can do neurosonogram, which is nothing but ultrasonogram, which we can perform through the fontanelles. But please remember, neurosonogram is a screening test only because it can miss so many diagnoses, because only a small part of the brain is visualized by this neurosonogram, and the main role of neurosonogram is to rule out other pathologies like significant intracranial hemorrhages. Are you able to follow this? So neurosonogram is only a screening test. So if the question comes, what is the definitive investigation? The definitive investigation is MRI of the brain, magnetic resonance imaging of the brain, and that too in the early stages. If you want to know the pattern of injury, you have to do something called DWI, which is nothing but diffusion weighted imaging. Why this is important to know? Because in the early stages, a conventional MRI may not pick up the findings of brain damage. So diffusion weighted imaging comes into play, wherein it will show abnormalities within a few hours after birth. Okay, so that is why MRI brain, which is diffusion weighted imaging, is supposed to be a better investigation in cases of hypoxic ischemic encephalopathy, simply because it can show the early changes very clearly. Okay, right. So having seen about the features of HIE and investigations in HIE, you should know about treatment. Please remember, there is no treatment which can completely cure HIE. It is more of a supportive management. Like you have to maintain the blood sugars, maintain the temperature, as well as give fluids to the baby. Okay, that is what we can do in the supportive management. Okay, and one more important aspect of management of HIE is to detect seizure and treat them. And this can be accomplished with a EEG technique called AEG. A here stands for amplitude or amplification. Okay, it's actually called amplitude integrated EEG, wherein it is used for bedside monitoring of seizure activity in a newborn. Okay, how it is different from a conventional EEG? A conventional EEG will have around 16 electrodes placed on the head and requires interpretation by an expert. However, AEG is a simplified form wherein only 1 or 2 electrodes are used over the head. The chief advantage is bedside monitoring as well as for continuous monitoring of seizure activity. Okay, so it helps in the detection of subclinical seizure activity while the baby is inside the ICU. That is a main advantage of AEG. But please remember, AEG should only be used as a screening test only. The diagnostic test for neonatal seizure will always remain as conventional EEG only. Okay, right. Now for the management of seizures, what should be the drug which is used? The drug of choice is phenobarbital. Phenobarbital. That will control most of the neonatal seizures. If phenobarbital is not controlling the seizures, the second choice drug was previously phenytoin. If that is also not controlled, you use benzodiazepine like a lorazepam. Okay, this was the usual management. But nowadays, what is being mentioned in the text is, if phenobarbital doesn't control the neonatal seizures, the second choice drug would be levetiracetam. That is found to be more effective in controlling the seizures which are not controlled by phenobarbital. So remember, at present, the first drug to be used is phenobarbital. The second drug to be used is levetiracetam for control of neonatal seizures. One more important aspect in the management of HIE is something called as therapeutic hypothermia. A very important intervention now gaining popularity in many of the NICUs is therapeutic hypothermia. So what it is, basically you are inducing hypothermia in a baby, right? So what do? You create something like a hypothermic environment in the baby by placing some ice packs around the baby or something like cooling crystals around the baby. The entire body can be covered, which is what we call it as whole body cooling. Whole body cooling. Or only the head can be covered. It is called selective head cooling. If a question is asked like which is the preferred form of hypothermia, it is whole body cooling, because whole body cooling results in a more uniform cooling and a better outcome in babies. So that is why it is preferred. Okay, so hypothermia means low temperatures. Exactly what is the temperature maintained in this intervention? It is around 33.5 degree centigrade. The range of hypothermia is 33 to 34 degrees centigrade, but typically the average temperature which is maintained is 33.5 degree centigrade. Now we should know how this therapeutic hypothermia is going to bring about a change in the baby's condition. Okay, it is said that hypothermia decreases the neuronal injury by decreasing the apoptosis of the neuron, number one. Second, it decreases the generation of harmful substances in the brain. Like for example, it decreases the production of free radicals, decreases the production of nitric oxide, as well as decrease the production of excitatory amino acids like glutamates, all of which are found to have an effect in damaging the neurons of the brain. Third, it also decreases the incidence of seizures in the newborn. So by all these effects, hypothermia is found to be beneficial in babies with hypoxic ischemic encephalopathy. Okay, the last thing which you have to remember is what is the criteria for selecting babies for hypothermia. Remember, all babies you cannot advise hypothermia. Okay, only for babies who are having a gestational age of more than 36 weeks, or we can also remember post-menstrual age of more than 36 weeks of gestation, and birth weight of more than or equal to 2 kilograms, they can be chosen for therapeutic hypothermia. Next is babies in stage 2 or stage 3 HIE only, therapeutic hypothermia is advised. If you think logically, stage 1 is like a mild stage, right? They don't require therapeutic hypothermia. Very simple. Okay. And to be effective, therapeutic hypothermia should be started within 6 hours after birth. Okay. And the usual duration of therapeutic hypothermia is around 72 hours. Okay, these are the important things which are included under the criteria for therapeutic hypothermia. Okay, so please remember, it's a new management but found to improve the outcome of babies with hypoxic ischemic encephalopathy. So that completes our discussion of birth asphyxia and HIE in a newborn. Please remember few important points. Birth asphyxia is a baby not breathing at the time of birth, and because of not breathing, brain is the most important organ affected in the form of hypoxic ischemic encephalopathy. Remember, HIE stage 2 and stage 3 are severe forms, and stage 3 is the most severe form. Okay, and babies in the stage 3, either they die or the babies who recover, all of them will develop neurological sequelae. The neurological sequelae depends on what part of the brain is affected. In a term baby, typically you get parasagittal infarction, and in a preterm baby, typically you get periventricular leukomalacia. And remember, treatment of HIE is only supportive treatment, like seizures have to be controlled with phenobarbital, and a new treatment option which I've described in the last is therapeutic hypothermia.
The next disorder I'm going to discuss is regarding neonatal seizures. Now please remember, seizures in a neonate are slightly different from the seizures in the older children. Basically because it's relating to the immaturity of the nervous system in a neonate. I'll tell you some related points about that as I'm going to discuss. First, you need to know about a certain type of seizures. Now you can see that the first seizure type I have written is subtle. You all might have studied about the other types like tonic seizures, clonic seizures and all, but here I am writing something different. Subtle seizure. This is supposed to be the most common type of seizure pattern which occurs in children. What is the meaning of subtle? Literal meaning means subtle means minimal. That means instead of having too much or florid manifestation, baby has very limited or very minimal manifestation. The example would be something like this: ocular movements. The baby would have just like a deviation of eyes to one side for a few seconds, that's all. Or something like continuous blinking of the eyes for a few seconds, that's all. That's one type of subtle seizure. They can also have this orofacial lingual movements. Example in the form of chewing movements, right? Continuously chewing movement. That can be one thing. Next is that in the limbs, the baby may be having some type of the cycling movements of the limbs. Okay, that's all. They may not have florid manifestation. What is the reason? It is related to immaturity of the brain and the synapses inside the brain. The connections inside the brain are not well developed. So that is why even if a seizure causing impulse is generated inside the brain, it may not be transmitted very rapidly to the other parts of the brain to cause a florid manifestation. That's why I say that subtle seizures are the most common type of neonatal seizures. Other type of seizures also can occur, but most importantly it is a subtle seizures, right? Now, from a prognosis point of view, I want you to remember this very important fact. Myoclonic seizures has got the worst prognosis. Among all the seizure types, myoclonic seizures has got the worst prognosis, and the focal clonic seizures, they have got the best prognosis in terms of the outcome. Okay, right. This you need to remember. That's about the seizure types. Now let us look at what are the causes of the seizure or etiology of the seizure. Please remember for example, the most common cause of neonatal seizure is hypoxic encephalopathy. That is a just concluded topic. HI is the most common type of seizures. Okay, around 50 to 60% cases of seizures, they occur in the first day of life itself, and that too within 12 hours itself they are going to occur. That is the most common time at which seizures occur in HIE. Within the first 24 hours as a general thing you can remember, but within first 12 hours is most of the seizures are going to occur, right? That is the most common cause. The second type of cause is the metabolic causes. Okay, here there are some typical example which you need to remember. Okay, I think they are very important neonatal seizure. One is hypoglycemia, second is hypocalcemia. In fact, it is always very, very important that once you start taking the investigations in neonatal seizures, blood sugar measurements as well as the serum calcium measurements are very, very important, because they are all easily correctable cause of neonatal seizure. So that is why metabolic cause like hypoglycemia, hypocalcemia are given priority. The third metabolic cause, even though not very common, but you need to remember, is hypomagnesemia. Magnesemia, right? So that is you need to remember. Okay, metabolic causes. Now infections. Okay, infections like sepsis, neonatal sepsis can manifest as seizures, number one. And second group of infection which you should always think about is torch infection. We are going to have a separate module on the torch infection. Torch infection is nothing but the intrauterine infections I am talking about. Torch infection can manifest with seizures in the neonatal period, right? And the fourth category is obviously going to be some form of intracranial hemorrhage. The examples I have already told you. In a preterm baby, I told you while discussing in that module itself, it is an intraventricular hemorrhage which is the most common type. And in a term baby, other type of hemorrhages can occur. And the common type of hemorrhage which can occur in the term baby is something called a subarachnoid hemorrhage. But please remember, this subarachnoid hemorrhage is unlike the hemorrhage which occurs in the adults and all, where the outcome is not very good. Here the outcome is good. This has got a good outcome. Please make a note of it. Probably because the amount of bleed will be very, very less here. That may be the reason. It is associated with a good outcome, subarachnoid hemorrhage, and usually occurs in the term baby, right? That you need to remember. The next group of condition which can cause neonatal seizures is developmental defect. That means defects in the development of the brain. For example, congenital anomalies of the brain. For example, anencephaly and all, which we'll be discussing under the nervous system module. As of now, remember developmental defects of the brain. That's all. Okay, right. Now, I'm going to tell you one last thing here. This is a rare cause of neonatal seizure. But please remember, this cause of neonatal seizure typically manifest as refractory seizure. Refractory means what? Not responding to the usual medication. That's called refractory seizures. What is that cause of refractory seizures? Please remember for your exams, it is something which is important for you to know because it's one of the treatable causes also. It is called as pyridoxine deficiency seizures, or it is also called as pyridoxine dependent seizures, right? How is this pyridoxine deficiency related to this seizure occurrence, right? Very simple. You must be knowing some neurotransmitters of the brain. What are they? Excitatory neurotransmitter called glutamate and inhibitory neurotransmitter called GABA, right? Now, what facilitates this conversion of glutamate into GABA? It is something called as GAD. What is this GAD? Glutamic acid decarboxylase. And for this glutamic acid decarboxylase to function, it requires the help of this pyridoxine or vitamin B6, right? So imagine that there is a deficiency of pyridoxine. So what is going to happen? The GABA will not be produced in the normal amount. So there is going to be GABA deficiency, and not only that, there is going to be associated increase in the levels of glutamate because it's not getting converted to GABA. So here you are having more of glutamate. What is glutamate? It's a excitatory neurotransmitter, and less of GABA, which is an inhibitory neurotransmitter. So more excitatory neurotransmitter will result in the development of seizures in the newborn. This is what is a proposed mechanism for pyridoxine dependency or deficiency associated with refractory seizures in the newborn you need to know about. Right? So we have covered about the causes of neonatal seizure and the manifestations of neonatal seizure. Now, next thing is regarding how are you going to manage a baby with neonatal seizure. Always remember, in any case of seizure, not only neonate, in other age groups also, always it is the management starts with stabilization of the vital parameters, and that is what we call as TABC. What is that? Temperature, airway, breathing, circulation. Everything has to be stabilized. Okay, especially this oxygen support may be required for seizures in the neonate. Okay, so immediately connect the oxygen hood or the prongs, okay, to provide oxygen support to the baby, and keep the baby under warmer because its temperature is also equally important. So first, stabilization of vital, temperature, airway, breathing, and circulation. Okay, right. Once that is done, okay, you try to look for the correctable causes. For example, correction of hypoglycemia and hypocalcemia, right? That can be done. Okay. Now, after this, you have to go for anti-epileptic drug therapy. Very, very important. I have told you in the previous module itself, what is the drug of choice in case of neonatal seizure? They ask you, always remember the first line drug is phenobarbital. Please make a note of it. Phenobarbital. That is the first line treatment. Usual route by which phenobarbital is given is intravenous route. Don't forget it. Okay, right. Now, if phenobarbital is not controlling the seizures, then the second line drug would be phenytoin followed by the benzodiazepines. Please know this order in which you are going to treat the neonatal seizure, because based on this you can get questions. Okay, right. Now, suppose even after giving these drugs, okay, if the seizure doesn't get control, it's called as refractory seizures, right? And one very, very important therapeutic option you have to consider in the refractory seizures is what? That's what I told you. Pyridoxine deficiency. You give a trial of pyridoxine. This has been asked in one of your recently concluded institute exams. Okay, so please make a note of it. Okay, right. So that concludes our discussion about management of neonatal seizures.